Kevin Campbell. I'm a urologist at Gainesville, Florida.
And I'm Blair Stocks. I'm a urology fellow in Houston, Texas right now.
So we're going to be talking about a recent study looking at the use of testosterone in men of reproductive age years. So to give a broad overview, we know that there's over 3 million men in the United States who use testosterone, and there's an increasing prevalence of men who use testosterone of reproductive age years. So with that, we know there's a suppressive effect of testosterone on the central axis and then telling the testicles to produce sperm and produce their own testosterone. So with that, there's this article that we're going to be talking about today. So Larry, can you tell us a little bit about the article?
Yeah, sure. So this is a retrospective study taking place at the University of Miami and basically looked at men who presented to a urology clinic and over a 4-year period, and then looked at prior testosterone use, and then if these men were on testosterone, then actually quantified thereof sort of their semen parameters and grouped them into different groups of being azospermic or no sperm, severely oligospermic, meaning less than 5 million per cc, or oligospermic being less than 15. And then from that, looked at their outcomes. And maybe you want to talk a little bit about sort of the strategy they use to try to rescue those numbers in the men?
Certainly. We have a lot of different options for trying to restore spermatogenesis, some great, some not so great. And so we're trying to maintain the testicles' own production of their testosterone and sperm. So we're using gonadotropin therapy with HCG and FSH or both. And then Clomid. So we're trying to use selective estrogen receptor modulators to trick the brain into thinking we need to make more of our own gonadotropins. And so the authors of this study, they used HCG, so a luteinizing hormone analog, as well as Clomid, so a SERM. They did this for 6 months, and they then looked at 45 patients and then saw that about 18 of these patients increased their semen parameters from either azospermic to oligospermic to normospermic. So it was something that a lot of us use, and I think it kind of hits home on that there still are many men who use testosterone therapy who we try to stimulate sperm production in, who still have difficulty with restoring that sperm production, who will need assistance. So is that something you see in your practice?
Yeah, no, and I think just another benefit of the paper was they actually did a somewhat prospective review of these patients and actually looked at fertility outcomes and of the men undergoing this treatment to sort of reboot their spermatogenesis, what was their actually fertility outcomes. And without getting into the weeds, they did find some patients and their partners were able to achieve natural pregnancies, but a significant portion still had to go assisted reproductive technologies, either IVF or ICSI, due to these severe sperm counts. So I think overall it's a good paper, one, just from a public health perspective, to bring up the concept that not all guys know that when they're on testosterone replacement, that they may lose their ability to father because they become azospermic or oligospermic. So really getting the concept out there that, if we're starting testosterone therapy, we really need to be counseling, not just in the clinic, but in the whole public health arena about the potential loss of fertility going forward. So I think, that's sort of my takeaway, but you were sort of also getting at, so how do we look at this in our clinic?
Right. How does it, we see this often. I think this is not novel to one institution. It's kind of something that we see on the landscape, especially as testosterone replacement therapy is becoming more and more widespread, and it's just continuing to be utilized. And so with more men of reproductive age years doing this, what are you employing in your practice and in your clinic to assist with this?
Yeah, so again, I'm a fellow with Dr. Lipschultz in Baylor College of Medicine, so he was actually one of the ones who pioneered this whole reboot process where it's HCG and Clomid, but we're sort of tailing into a different direction now with the availability of less expensive options of FSH. So instead of using a SERM like Clomid to trick your pituitary gland into making more of that FSH, we're actually combining HCG as well as FSH therapy directly to have that maximal effect on the testicle. So we have a little exciting data at this conference that's actually looking at sort of the benefit of maybe this more advanced therapy rather than having to use a SERM. So we've sort of trended away from the HCG Clomid more to the HCG FSH side of things and have some exciting data regarding that.
Yeah, that's fantastic. And looking at the Houston, the Baylor group, there was an abstract 2 years ago at SMSNA They looked at the use of HCG and FSH versus HCG and Clomid and saw that the people who were on previous testosterone use and then stopped and started their HCG and Clomid versus the HCG and FSH had an actual slower return of sperm to their ejaculate, whereas the men on the FSH and HCG, just that strict regimen which you're discussing, had sperm return in 6 months approximately.
Yeah, no, with that too, luckily we've actually been able to expand on that data set too, with our protocol, and actually have over 100, 150 men undergoing this protocol. So we're really excited to look at this data going forward. But overall, I think getting guys to a place where they can have kids is possible. We just need to think about also the context of the testosterone replacement they were on as well.
Absolutely. And so I think some of the takeaways really from these discussion points, this paper, and what we look at in a clinical setting is that many of these men are going to have hypogonadal symptoms. Many of these men need treatment for their testosterone deficiency, but as you said, Blair, a lot of these men also are going to need assistance with improving their reproductive health, and so we have to keep that in mind whenever we're putting men on testosterone therapy.
And then just another talking point I wanted to bring up too is a lot of patients that you may have seen, on previous testosterone replacement now that come to you as a urologist may have been seen at one of those low T centers where it's just strictly testosterone therapy. They're not getting anything concurrently. So another point that I'd like to bring up is if we have these patients and they are now capturing them in our urologic practice, should we also be giving them concomitant HCG at the time of testosterone therapy just to preserving going forward, even if they're not ready for childbearing years, at least to preserve that endogenous spermatogenesis and sperm production. So just better awareness of mono T therapy, whether it's at a low T center or the gym or somewhere else, really needs to probably have a little more fertility goals in mind, and maybe even adding HCG concurrently to preserve spermatogenesis, which is something one of our previous mentors showed about 10 years ago, that you can actually preserve sperm function on testosterone therapy if you give HCG at the same time.
Absolutely. All right. Well, thank you for your attention and thank you for watching.